Nursing is one of the best-paid jobs in America that doesn't require a 4-year detour into an office. The median registered nurse makes more than $90,000 a year. Every hospital in the country says it is desperate to hire them. And yet, 4-year and graduate nursing programs turned away more than 90,000 qualified applications last year. Read that again. We are short on nurses, hospitals are begging, the pay is good, people want in, and the doors are being shut. Something in this story doesn't add up, so let's take it apart like an operator. In January of 2023, about 7,000 nurses in New York City walked off the job at 2 major hospital systems. Here's the part that matters. The strike wasn't mainly about the paycheck. They got raises, but the fight they were willing to walk out over was about how many patients each nurse had to cover at once. Too many, they said, to keep people safe. And what they won in the end wasn't just money. It was enforceable limits on their workload. Hold on to that. In many recent nursing strikes, the flashpoint hasn't been the salary. It's been the load. So let's answer it precisely. Not why aren't there enough nurses, because in raw numbers, there have never been more. The real question is, why, with good pay and record numbers of trained nurses, can't hospitals keep enough of them at the bedside? The answer is 3 things stacked on top of each other. A pipeline that's capped in a strange place, a bedside that pushes people out, and a fix hospitals keep reaching for that quietly makes it worse. Start with the pay, because it's the part that makes this confusing. The median registered nurse in America earns about $93,000 a year. That's well above the median for all workers. Nursing is, by the numbers, a good job, stable, respected, well compensated. So the standard story, nobody wants to do it, so just pay more to create more nurses, doesn't fit the top-line numbers. The pay is already high. As we'll see, how that pay is structured still matters, but a simple raise isn't the missing piece. Here's the reframe that changes everything. There are more licensed nurses in the United States than at any point in history. Over 3 million working, and by one nurses' union estimate, more than 1 million more who hold a license but aren't working as nurses right now. So the country isn't mainly running out of trained nurses. It's struggling to keep them in the hardest jobs, the hospital bedside, nights, weekends, holidays, caring for the sickest patients, and to get them where they're needed. Because the shortage is also uneven. Federal projections show some states running short, while others have more nurses than they can use. That's not mainly a manufacturing problem. It's a retention and distribution problem. And you fix those very differently than you fix a factory. Now the pipeline, because it has a strange kink in it. Interest in nursing is not the problem. Applications are up, and schools are full. The problem is capacity. In one recent year, 4-year and graduate nursing programs turned away more than 90,000 qualified applications. Not unqualified, qualified. People who met the bar and still couldn't get a seat. So why can't the schools just take more? Because a nursing school runs on nursing faculty, and there aren't enough of them. By the nursing college's own count, roughly 7% of faculty positions sit vacant, and the faculty who remain skew older with a wave of retirements coming. Most of those open jobs prefer a doctorate, which takes years to earn. And here's the twist that ties it all together. Teaching often pays less than working at the bedside or in advanced practice. So the very wage pressure that pushes experienced nurses around the system also keeps them from becoming the teachers who train the next wave. The pipeline is capped by a shortage of teachers, not a shortage of students. So set the pipeline aside. Even with the schools capped, we still train tens of thousands of new nurses every year. The deeper question is what happens after. Because a huge share of the shortage isn't nurses who never existed, it's nurses who trained, worked, and then walked away from the bedside. To understand the shortage, you have to understand why people leave a job that pays this well. The warning sign is loud. In a 2024 national survey, about 4 in 10 nurses said they intend to leave the nursing workforce within 5 years. Now, that's what they say they intend, not a guarantee they'll go. People vent, but when nearly half your workforce is telling you they're eyeing the exit, that's not noise. That's a system running on people who are already halfway out the door. Ask them why, and the same word comes back: burnout. In a 2023 survey, 56% of nurses reported burnout, emotional exhaustion from the work itself. Nearly two-thirds said the job brought them a great deal of stress. And burnout in nursing isn't vague unhappiness. It has a specific physical cause you can point to. It's the load. Four forces do most of the pushing. First, too many patients per nurse at once, the exact thing the New York strike was about. Second, mandatory overtime. In most of the country, there's no federal limit on being ordered to stay past your shift. Third, wage compression. Nursing pay rises fast in the first few years and then flattens, so a long-time nurse's pay can end up surprisingly close to a newcomer's, which quietly punishes staying. And fourth, what nurses call moral injury. Being forced by short staffing to give care you know isn't good enough. Good starting pay is real. It just doesn't cancel any of those out. And the load isn't just about whether nurses are comfortable. It's about whether patients live. A landmark study back in 2002 found that for every additional patient piled onto a nurse's assignment, the odds of a surgical patient dying within a month went up by about 7%. That was an observational study, now over 20 years old. But later research, including a national ratio law in Australia, has pointed the same direction. So when nurses say the ratios are unsafe, they aren't being dramatic. They're pointing at a measured association. You can watch the strain show up and then partly recede. This is hospital nurse turnover, the share of bedside nurses who leave their job in a year, from an industry survey. In 2020, before the pandemic, it sat around 19%. By 2021, it spiked to over 27%, more than a quarter of the bedside workforce turning over in a single year. It has since come back down, close to where it started, around 18%. So the crisis spike has passed, but sit with the baseline it returned to. A bedside where nearly 1 in 5 nurses leaves every single year was never healthy to begin with. So how do hospitals cover the gap when their own nurses leave? Mostly they rent replacements, travel nurses, contract nurses who parachute in for a few months. And they cost the hospital far more. By one industry survey, a traveler runs the hospital about $91 an hour, all in, versus about $59 for a staff nurse in the same unit. That $91 isn't the nurse's paycheck. A big cut goes to the staffing agency, but it's what the hospital pays. Now put yourself in the shoes of the staff nurse carrying the same load beside a traveler the hospital is paying 50% more to have there. You can see the strain. More than 70% of hospitals say they want to cut their reliance on travel labor because it's expensive, and many nurse leaders argue because leaning on it can wear on the staff who stayed. And every nurse who leaves is expensive to replace. By industry estimates, losing and replacing a single bedside nurse runs around $60,000, recruiting, onboarding, lost productivity, and the travel nurse you rent to cover the gap in the meantime. Multiply that across a whole hospital's churn, and retention stops being a soft human resources nicety. It becomes one of the biggest controllable costs in the building, which raises the obvious question: what actually keeps nurses at the bedside? Here's the encouraging part. We are not guessing about what works. There's a natural experiment that's been running for 20 years in the country's biggest state. In 2004, California became the only state to put hard limits into law on how many patients a hospital nurse can be assigned at once. 1 nurse to 2 patients in intensive care, 1 to 5 on a general floor. It is about as close as American healthcare gets to a natural experiment. When researchers compared California to states without the law, the pattern lined up. California nurses each carried about 1 fewer patient. And in one study, California hospitals had lower surgical mortality, roughly 14% lower than New Jersey and 10% lower than Pennsylvania. It's an observational comparison, not a lab. California differs from other states in many ways. So it can't prove the law alone caused the gap, but the direction is consistent, and it's the strongest evidence we have. The conditions followed. In a separate study, California nurses reported burnout around 40%, against 45% in comparable states without ratios. They averaged under 4 patients each. Nurses elsewhere carried closer to 5. And every extra patient, the same study found, raised a nurse's odds of burnout by about 12%. Fewer patients per nurse, measurably less burnout. Fewer people heading for the door. The lever works, it's just expensive. And hospitals fight it, because more nurses per patient means hiring more nurses. And ratios aren't the only thing that works. When researchers look at what actually keeps nurses, the same levers show up. Manageable patient loads, real mentorship for new graduates. In studies, structured residency programs lift first-year retention from the mid-80s into the mid-90s and giving nurses genuine control over their own schedules. Notice what's not at the top of that list. A bigger signing bonus by itself. A bonus fills a seat once. It does little about the reason the last person left. Retention is built by the daily job, not the offer letter. So put the whole thing together. We train fewer nurses than we could because there aren't enough teachers to grow the schools. The ones we do train often burn out at the bedside and move to easier settings, or out of hospitals entirely. Hospitals plug the holes with expensive travelers, which drains money and, many argue, morale from the nurses who stayed. They cluster in some regions and thin out in others. And underneath all of it, both the nurses and their patients are aging at the same time. A workforce retiring straight into a rising wave of demand. It is not, at its core, a story about too few nurses being made. It's a story about too few nurses kept and evenly spread at the bedside. If you want the operator's view of how healthcare actually works, the systems behind the headlines, in plain English, the breakdowns are at shanewelter.com/free. Next question in this series. Hospitals are closing across rural America, whole counties losing the only emergency room for an hour in any direction. Why is it happening? And why almost always in the same kinds of places? That one comes down to the math of keeping the doors open.